Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro in, I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. We are back on our tour of Motol Hospital here in Prague, Czech Republic.
I feel a little bit more at home now because this is what, now I'm feeling a little more.
Yeah.
We're out of our element.
Because we can cheer. We were at coffee the last couple times, but now we're actually getting to it. And so our next guest, Yulia Demekova. Oh, I almost got it right. Yulia Demekova. She's been with DNS now for 15 years teaching. Today, what our main topic is, Brett, I want to talk about neurologic patients. You have kind of a specialty here at the hospital, treating patients kind of after a stroke or, partial paralysis or things like that. But then not only treating them passively, maybe what the normal model is, but then mixing and matching passive care with active care. And we just learned too that you teach with the physical therapy department of that thing right there, teaching the passive modalities, but how they can interplay in with active care.
Exactly.
And yeah. So thank you for being here with us, but maybe just kind of give us your brief, just a quick kind of hitter. How'd you end up at Motol? How'd you end up here and with DNS, put it that way?
Oh, thank you very much for this question. So my stay in Motol and being here, it's everything accidental because I finished my university education. I graduated in Moravia, and really far away was my idea to come to Prague because I still had a feeling that I was supposed to come back home to Slovakia. And as far as I've been working for 2 years with my colleagues in some small spa in Moravia, one of my friends said, okay, you do not want to be stuck in such a small village. So I will call to Pavel and maybe he can admit you as the worker there. I said, Pavel, like a Pavel Kolat, like this, like a big guy. Definitely he's not going to admit me because he doesn't know me and I am no one for him. But word give a word, and I appeared here in 2009, and since 2009 in September, I'm here for 14 years.
That is beautiful.
Yeah.
Well, kind of take us through your position then with teaching this passive care model, and then kind of how you're teaching that model. We'll put it that way, and then adding in active care with the passive stuff.
As far as I had a very good teacher on university education, Dr. Podjebratsky, which has been a very good basement for the physical therapy in Czech Republic. I came here and that was something what was very required because the colleague which have been teaching these passive techniques have been quitting here in Motol, and automatically it was my duty because everybody know that my person is someone who can continue. So I try to find out the passion in it because the physical therapy is something what is the topic for learning, for understanding how we can use this passive technique really in well-indicated procedures for patient to improve their symptoms. And completely it made a sense for me as far as I started to work more with the DNS, because it just been as a next tool for me which I can use to get better result.
Why do you think these patients are so neglected? It's the same way in the United States. I feel like if there's neurologic compromise, the therapists are sometimes afraid to work with them. The hospital systems, they're definitely, guilty of not implementing a lot of these active care programs. Why do you think that is?
I think that the passive treatment is something what it's admitted by people because they used to do it in this way. So it's easy to lie down and be affected by magnetic field. You do not need to do nothing. So it's also the perspective of the patients, but also for the therapist, it's much easier just to switch on the button on the machine and to wait for 30 minutes. And maybe some result will come, maybe some result will appear, but it's not appearing so far away. But anyway, the insurance companies are paying us, so God bless, we can stay and we can survive. Yeah. So absolutely, I think that this is the approach of the people. And if they are active in their mind and in their soul, they will definitely search for active approach. If they are not, the passive treatment will be only solution which they can find out.
Right. And how much do you have to modify what you typically are doing, like with the normal population? So when you're dealing with spasticity and things like that, like what are the modifications that you have to do to be able to even get them in certain positions that we use for active care?
Oh my God, a lot of modifications have to be done.
Yeah.
So there are a lot of modifications. So in an active treatment, the neurological patient is a big task. It's something what it's inspiration for me because every patient looks a bit differently at reacting differently on the treatment, and not in every patient, even when he has the similar diagnosis as the one who've been before him, is reacting on the treatment differently, and we do have a goal of the treatment in the different way. And this is something where I feel it's very important because if I do have a goal for the next month that I want to improve the support function of the lower extremity in spastic patient, I'm doing all the things which can be done for it. So it's nothing that it will be completely the same as the patient before, because also maybe he needs to improve the same function, but maybe he has a less spasticity or the bigger spasticity. He can have some limitation in range of motion, and everything is the question of modification, how I can achieve the best result.
Well, I think usually in DNS, we're trying to, fix compensatory patterns, but actually in some of these patients, we're in a way almost teaching them to compensate better in a way.
Exactly.
Right?
So this is completely different approach.
Goal.
It's a completely different goal for the treatment because in some of them, the pathological condition can be very helpful, and we would like to keep it because if we will decrease it, as for example, spasticity of lower extremity in the spinal cord injuries, those of them who need them for the transfer from the sitting on the wheelchair to the sitting to the bed, if we will decrease it, they will be not able to do it anymore. So the goal of the treatment is really varying independently.
And are you utilizing a lot of reflex locomotion now, a little bit, like on these patients? Or
so neurological patients are the perfect group of the patient for the indication for reflex locomotion. Yeah. Absolutely. Because as far as they cannot activate some muscle groups or some muscle functions voluntarily, this is a perfect tool how to get it.
And then how do you utilize DNS with these patients? I know that's a broad question, but is it as simple just putting them in developmental positions, or like how does your approach different, I guess,
or is there like a continuum? Do you maybe start reflex locomotion passive, and then once they get to a certain stage, are you switching to DNS?
Hard to say if I'm starting with the reflex locomotion. In most of them, definitely this is a big part of the treatment. Combination with the active exercise makes a sense for me because even when I will turn on the activity of some muscles via the reflex locomotion stimulation, it doesn't mean that the CNS will automatically apply it in the daily life. So I need to catch it and force it by the active exercise. So if I would like to do it, for me, it's pretty clear that I'm using developmental positions, but some of them, they are not the developmental positions. They are the positions from their normal life which they can stay in, and they need to improve the quality of the movement because anyway, if they will get overloaded, they don't have any other compensatory mechanisms. So this is something what we need to take care about.
I feel like, at least for myself, that I'm better off as a clinician working with patients who have spasticity and things. It actually helps me for my everyday patients also, because you kind of see what it looks like on a continuum.
Yeah.
Would you agree with that? Would you? Because I know you work with everyday orthopedic cases also, but do you think with all this work with spasticity that it's actually making you a better clinician for your everyday patients?
Be honest, I think that yes, because the working with the spasticity broadened my way of the thinking in the realizing what is important, what should be the goal for the orthopedic patients.
Right.
Yeah. So and of course, the big benefit of orthopedic patients is no limitation of the hypertonicity
Right. Yeah, right.
of muscles. So absolutely, this is crucial. Yes, I think that working with the neurological patients helped me a lot.
And then how much are you guys utilizing Botox, like diagnostically or treatment and, other, I guess, pharmaceuticals that are also assisting you with these patients?
We do the kind of the assessment which can be also according to DNS. So we can do the functional assessment. But from the different perspective, we use also the assessment which is according Vojta. And this is called locomotor stadiums, according Vojta, which is pretty similar to the locomotion stages, which are described for the cerebral palsy in kids. So it's modified for the spinal cord injuries. So this kind of the test we can apply for the spinal cord injuries patient. And also it's very important to do the functional test also for the every neurological patient, because the neurological limitation is pretty clear. But the question is, what this neurological or clinical picture has an effect for the clinic, for the activities of the daily life.
Now, are these modified postural reaction tests that you're doing for Vojta, or what are the tests?
No, this is not the postural reactions.
Different.
They are the tests which are just assuming what's the level of the patient to address him or his task for the treatment more properly. And also there is a chance to control and check in a time how he can proceed, if he is getting better or he's not getting better and he's staying in the same stage of the functional abilities.
Right. Go ahead.
I was just going to ask, then circling back, how much is pharmaceuticals playing into that? Botox, tendon releases, things like that. Like where does that continue
Surgical
to play
releases.
Yeah, things like that.
We do have here, so this is a big benefit of being in hospital. We do have here the department, or it's not the department, it's part of our clinic, the service which is served for the patients with the spasticity, so general neurological cases, in which we discuss and apply botulinum if needed according spasticity level. So there is provided the measurement which is according Gracies. So it's taken from France, because this is the kind of the scaling of the patients which is very popular nowadays, and according the researches it makes a sense to do it according these 5 steps of the assessment which is given by Gracies.
Do you find yourself, like when you start with a new patient in this category, that you are using younger developmental positions and then you're kind of working your way through development? Or do you think sometimes you might get more of a benefit from maybe a higher DNS position, just depending on the case? Or
if you will see me working, you sometimes maybe can have a feeling that I'm really freaked out, because if I do have a chance, I'm diving these patients into really high developmental positions,
right,
just to gain as many things as I can. But of course, sometimes it's very demanding to let them to be there because of the lacking stability, decreased muscle power, or non-sensitivity from the distal segments of the body because of the CNS injury.
And then is there anything in your tool belt outside of DNS that you're using all the time with these patients? Like, are you doing, fascial manipulation, balance work, or I mean, what are the other things?
Or anything?
Yep. Yeah. So dry needling so far is still not very popular in Czech Republic because we do have a law which doesn't allow us to go through the skin of the patient so far. So I think it can.
They also have rules that you can't drink in a hospital too. We break them.
Yeah, but anyway, we are after the working time. Really,
that's right. We're past
it's
why
over
have
the,
rules
over
if you
the
can't break
time.
them?
Past business hours. Come on.
So, but anyway, that's also the reason why the physios are not educated in dry needling so far yet. And those of them, they are educated. They do have a permission to do it, but it's not me.
Sure.
So, but I am educated in the fascial manipulation according to So yes, I use it in those neurological patients, but it's not on the daily basis. What I do on the daily basis is application of some kind of the physical therapy.
And what are the diagnoses that you're actually working with most frequently? Like, what are the actual conditions? So are we talking stroke,
MS?
Yeah. So those are the most popular or the very typical in our department. So definitely they are the patients after stroke, the patients with multiple sclerosis, and also the peripheral paresis, which are autonomic and they are named by Charcot-Marie tooth. So it's a peripheral paresis, which is hereditary.
And what do you think the mechanism, let's just start with MS, like what is DNS offering the MS patient that if they don't have DNS that, they're not...
This is something what probably I can compare well because before the time when I've been working with the DNS, I did only some stuff which is well known here in Czech Republic. So we use the typical two kind of approaches, and this is the Bobat technique and the PNF, according Kabat, which both of the concepts come from Germany, and they are pretty good and working well. DNS is bringing the perspective of the very good muscle coordination. So we really not searching only the providing of the movement, but how well this movement is provided. And this is something what we want to get into the daily living of these patients, because we know, okay, of course, the limitation by the spasticity or the limitation by the range of motion is not allowing us to get the ideal movement pattern, but we don't want to have any just because we want to have the movement. So rather better movement pattern if it is possible to get it. And it's not only about that we are improving spastic extremities, but we can work on the trunk, we can work on the non-spastic extremities to somehow offer the central nervous system ability to use the spastic extremities in a better way.
Fair. What about, you mentioned before we got on Shockwave. Where does Shockwave play into patients with neurologic, maybe spasticity? Where are you finding utility in that?
Modalities in general.
Yeah, modalities in general. Yeah.
So the modalities general we can divide, and this is really like from the school and academic field. So we can divide according the main effects which we are searching for. So this definitely analgesic effect. We can decrease the muscle tone. We can work with the activity of the muscles or activation of the muscles, or we can increase the blood circulation in the specific area. So those are the main topics or main goals of the using of the physical therapy or general like in physical agencies in Czech Republic. So far, to just give you an answer for the shockwave treatment, in neurological patient, I can find out the very effective in the releasing, especially the segments around the shoulders or around the knees and feet, because I feel that this is the good process for the releasing of the very tight hypertonic muscles. So this can be very helpful because a lot of researchers are confirming all the time that the muscles which work in the spastic model, in spastic type, they are changing their structure. So this shockwave can help me to keep the structure longer lasting in the normal capacity.
So let's just take maybe the lower extremity in a spastic patient. You maybe decide that you're going to employ shockwave. Then would you do that first and then finish it up with DNS, or like what would be your continuum, I guess, of care along that line?
That's a good question, which probably doesn't have like a proper and only answer.
Yeah.
Absolutely, like a basic for me is to make an assessment and to see what's the type and which segments are or of the lower extremities are involved. So, and how far, of course, the spasticity and the range of motion is limited, and how it's limiting the gait. Because when we are talking about lower extremities, we have to touch the gait. So, and if I can see it, definitely the shockwave is not the first which is coming into my mind, because I think that it's fine to try to get the normal tonicity in the like a regular activation, because anyway the shockwave is pretty high intensity of the mechanical energy which is given into the body of the patient, and we have to realize that we do not work with the physiological structure of the muscles. We do not work with the structure which is completely physiological, in which we can expect some reactions. As far as this is a pathological condition already because of the central lesion, also the structure can be limited and can react a little bit differently. So this is not my first option.
Sure. I think too, I feel like in the United States, these patients, we're not seeing them enough to really be able to help them. Yeah. What does the average treatment plan look like? Are you seeing them a couple times a day, a couple times a week? Like, what does that all look like?
And for how long?
Yeah.
So if we do have let's give an example of the acute stroke patient. So generally he's hospitalized in our intensive care unit after the stroke, and when he's reacting on the rehabilitation provided there, well, he's indicated to transfer to our rehabilitation department. There, my colleagues, we work with those patients twice daily. So 2 exercises a day, 2 treatments, which last approximately 45 minutes. So they have 1.5 hours of the exercises, and immediately there we can admit or add some kind of passive exercises as a kind of the cycling or the activity of the upper extremities, which is passive. We can add some kind of the magnetic field treatment. We can add the electrical current treatment. Depends what's the main goal of the treatment. So this hospitalization very typically lasts for 2-3 weeks. Mm-hmm. And after that, the patients are transferred to our national centers, which are focused for neurological diseases. The most of the time also there, they do have at least 1 active exercise and a couple of the passive treatments a day, 6 days a week, and they stay there for 6-8 weeks. Wow. And after that, they are transferred to the outpatient department.
And since we're talking about stroke, so if a patient comes in and the stroke has affected their upper extremity, we of course see the classic presentation. What are some of the early interventions you think are like vitally important for the patient that is coming in with rigid spasticity in the upper extremity like this? And then we'll talk about the lower, but
the upper one. Yeah. So this is the part which our occupation therapists are taking care about well, I think. They are using kind of the air orthesis. So the orthesis, which is plastic one, and you can fulfill it with the air, and it's fulfilled, it's stretching the extremity, and it can be held there for 2 hours. So it's really having the effect for the shortened tissue, because it's not only stretching or the post-isometric relaxation, but it can last. Sustain, exactly.
So that's really important.
Yeah. So this is the very important thing. And next thing, what is very typically used in the spastic patient is the kind of the functional electrical stimulation, which can be used for upper as well for the lower extremity. In upper extremity, there is kind of a prosthesis which has 2 electrodes, and in between these electrodes, the low frequency currents run and activates nervus radialis, which activates the active dorsiflexion with radial duction, and also some part of this orthesis is helping to maintain the position of the upper extremity for example, grasping of the
critical
cap and to have it.
And then what from DNS? What are you using with what's your continuum kind of look like?
Generally, with these patients, I'm starting in some positions which are activating support function of the extremity, because to work with the phasic function when it's shortened, it's very hard. So I'm using the positions which can be used for the particular patient. So very typically I'm starting somewhere in the side-lying position, low or high oblique side, and I'm trying to evoke the activity which is in close kinematic chain to let the muscles in the same time stretch those of they are shortened and activate those which are pseudo-paretic, because they are not paretic.
Anything different for the lower, or kind of the same?
Of course, the position of the lower extremity, if it's not activated enough, I'm trying to add it, because central nervous system is still working with the global movement patterns. So even when I do have only spastic upper extremity, I can nicely work with the balancing of the pelvis. I can work with the lower extremity support even when it's not affected or it's not visibly affected. And I can reach the relaxing of the muscles in upper extremity as a reflex way of the reaction. So this is perfect, because it makes a sense as far as in the healthy people we can see these reactions. In neurological patients we have to use them.
So like DNS hanging, modified squat,
of course,
bear, like those are your
the modified positions. But as I said, I'm pretty jerky on my patients, and I'm going ahead. I'm putting them to the high positions, because I would like to get also the muscle activity of the segments which can work normally, to get them to feel they can work normally, and to affect the muscles which are working.
What about the continuum then? Let's say after, I don't know, we're a few months out from these cases. Where does home exercise play into this? Like, you know what I mean? You're maybe seeing them once a week in outpatient care or things like that. Then what does the home care look like in those situations?
So generally, they can do the home exercises. Absolutely. Yeah. Mm-hmm. Of course, they have to be modified and adapted accordingly. And the part of the exercises is also the kind of the protocol which is in the protocol of the spasticity relieving, and that is the repetitive activity of the antagonist muscle group. So again, this is something what we took from the Gracias approach, but it can be nicely applicated to the DNS, because if I do have a spasticity on the upper extremity, so it's the mainly affecting the biceps and the flexors in the forearm, I can rapidly activate my triceps to decrease tension on the biceps. And this is something what patients can do home. They are educated by my colleagues, which is working in this spasticity center.
And after a pretty significant stroke, is it reasonable that the prognosis is going to be that they can get them back to 100%? Or even when they're doing really well, do you still see hints of them still being dysfunctional? Or, what's the... I know every case is different.
Here I would like to say the quote of Professor Elena Kubesova, who all the time says, neurological patient will stay neurological patient. Right. So we cannot expect 100% recovery. Right. Still, there is a damage of the central nervous system, and this damaging, even when it is ischemic or it's the hemorrhagic, is not going to recover. So, of course, the limitation doesn't have to be pronounced much, but probably they will be there. And when the patient is young, in the eldering of the body, these limitations will be proceeded again.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar. November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brett Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Park University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
And how do you have those difficult conversations? Because I think we've all been there where like somebody is bringing a patient to you because they think you're going to create a miracle for them. So sometimes you got to almost in a way kind of be realistic on that. So what is your verbiage to explain to them like what their recovery is going to look like? Because you don't want to take wind out of their sails and, you know.
Yeah, sometimes it's very hard.
Yeah,
but very typically, I'm starting with again my very typical quote: "I am Julia, but I'm not Jesus."
I'm God.
I'm just God, but I'm not Jesus. This is something what, of course, I'm trying to like turn everything on the like a funny side of the situation, but when I have to speak clearly, I am sharp. So I'm trying to give still the hope, but also the realistic expectations. Because when somebody is coming with the unrealistic expectations, and he will be never happy about small successes, what should be done, because his expectations are much higher.
Yeah,
and this is something what it's like a business deal. Do you want me to help you with this position, this situation? I can. I'm not able to sell you the Ferrari if I'm just selling Fiat. Sorry, I cannot do it.
Right.
Yeah. So that's the from my perspective only way how on the both sides the satisfaction from work can appear.
What's the minimum amount of time, like treatments? How many minutes do you need to work with these patients? The reason I say this is a lot of our listeners, you know, they're in a system where they don't have like gobs of time. So what's the minimal amount of time that would still be beneficial to work or book these patients out?
I think if this patient can come to you, so he is not so limited by the movement, I think that the 20-25 minutes can be perfect.
Right.
Good to know.
Of course, every minute plus will benefit, but also 20 minutes can be a valuable time to work with them.
Yeah. And then these patients, we call it in the States, they get to what we call maximum therapeutic benefit, which basically means they're kind of stagnant, staying the same. Is it important to continue to treat these patients? Because like what happens in the States is you reach maximal therapeutic benefit and the insurance companies, they think that means, well, that's all we can do.
They're done. Yeah.
So how important is it even when you've kind of like, you know, got to a cul-de-sac or an ending point that we still treat them?
This is a perfect question. Short case, I've had a patient with a cerebral palsy. She's been 14 and she came to me with her grandmother, and they had a new prescription for the rehab. So my question, because I've never seen them before, so my question was, okay, so as far as you are CP for entire life. So what is your expectation for now? What is your goal of the treatment? And they said, I do have a cerebral palsy, so I am indicated for the rehab. I said, no, you are not indicated because you have cerebral palsy. You are indicated because we are going to improve some functions, which we can improve now, but not because you have a diagnosis of cerebral palsy. So also the patient with a stroke, even he will be after stroke in a month, but also in 5 years of the time. But in 5 years of the time, I will have completely different goal of the treatment. So of course, he can be indicated for rehab, but if he is not, because he is not cooperating, he doesn't have a compliance, so he is not indicated, and doesn't matter if he is after stroke. It's his problem from the different perspective.
What is your most amazing case that you're the most proud of that you almost hate to talk about? Because I think everybody in their career, you got one case that you look back on and you're like, wow, that was literally a miracle.
Yep. So I do have one.
You got two. Tell them both.
No, I do have one which I'm very proud of and also surprised. It's the patient with the peripheral paresis, the patient after surgery in low back, because he had the peripheral paresis of the peroneal nerve, and he had completely dropped foot, no reaction, really lax stability of the knee extension, and very limited hip control in the transversal plane. So radiculopathy, which affected L5 in the right lower extremity because of the overloading of the lumbar spine and really collapsing of the lumbar spine and the appearing of the radiculopathy. And I've been talking to neurologists all the time in my life. I believed that the peripheral nerve can recover almost fully. Doesn't matter on the length of the recovery. It matters just for the question of the time. And the neurologist told me, you are stupid. You cannot expect that the so long peripheral nerve can recover fully. I said, well, I've been teaching this my students, so I believe it. I said, the external recovery doesn't exist in those patients. Those one, he came and I said, okay.
Younger old guy.
Yeah, probably he is this type. So I'm very sorry. I will see what I can do. But the situation on the lower extremity was very, very bad. And after 1.5 years of work, he has described on EMG full external recovery.
Wow. That's awesome. That is awesome.
The miracles can happen, and we can just be as a part of it. And that's a perfect
Yeah, and I mean, those are like outlier cases. How accurate are you on a new patient exam on what their prognosis is going to be? So you go through all the tests that you're going to do. How confident are you to know what's possible with that patient from your initial examination?
So be honest. As older I am, less confident I am.
Same. Yeah, I would say exactly.
I'm still realizing
because everyone's got their own ability to compensate and adapt. You know,
exactly.
that's the thing you don't know in that assessment.
Perfectly said. Completely agree with you, Brad, because I do have completely the same feeling, and maybe the life or somebody over us try to teach us how to realize that everything is possible, not only by miracle, but really that everything is possible, and every body is different, and the abilities of the compensations are varying in the million possibilities. So as far as I am able to realize it, so it's connected with the time and age, of course. So I'm realizing the confidence in to say you will walk, or you will do not walk ever, or you will be able to stand up and you will be able to stabilize your pelvis. This confidence decreased a lot, but I can estimate, and of course I'm trying to give the hope to patients from the perspective of what I think it is possible. So still I'm giving like probably less presentation what can be done. Let them and me be surprised if something more will happen, rather than even this level is not fulfilled and they are unhappy because they expected miracle.
In the US, I feel like treatment of these patients, it's so specialized, meaning, you know, they have the cardiologist, they have the GIGU, they have, you know, all these different divisions, but I feel like you guys are a little bit better at talking and integrating with these different like specialties. Because if you're working with MS and these other cases, I mean, it's involving all these different systems. So in saying that, how much are you guys talking to these other specialists that are on the same case that are working?
If it's a chance, I'm trying to talk to everyone. So on the daily basis, we talk with the physiatrist, occupational therapist, psychologist, neurologist on the really like a daily basis. And of course with the nursing staff, which is in hospital. To talk to some other professions in medicine. Sometimes it takes time because they have to realize they can value our opinion. But anyway, we here in hospital, we do have a very good basement for our opinions because of Pavel.
Right.
Yeah, he built it our credit, and it's easier to discuss with those people which are pretty far away from rehab.
And I think I know, like being around you and others, like you guys, I feel like are so far ahead of like what's getting done in the United States on the topic that we just talked about. But sometimes like in the United States, we're good in other areas like functional medicine, nutrition, like some of those things. Do you see that kind of creeping into the treatment of these MS? Like, because we have a whole functional medicine side for like the MS patient, for example. Like, are you guys starting to get into changing their diet, like this whole movement of like nutrition and things like that for these patients?
Yes, the programs for those patients exist. They can easily find it because they do have web pages which are really informing well about the options for the nutrition, for the kind of the conditional exercises, what they can provide in the social care. Really,
right.
they are very educative, and we do have also MS centers which take care directly only those patients, and they are giving really like wide sphere of the treatment, not only the rehab treatment.
And I feel like MS, like the guidelines have really changed in the last couple of years. I mean, I'm old enough to where when I was young, like we were warned that we have to like be sure they never get overheated, that we don't work them too hard.
Yeah.
And now it's kind of shifted a little bit. Not only do we not overwork them, but it's actually okay to work them maybe a little bit beyond their capacity, just because that's good for plasticity and, you know.
Exactly. And you can find out a lot of MS patients which love to have a vacation somewhere nearby the ocean. And they really like it, take a sunbathing, and they are fine. So it's important just to realize which kind of advices we can put to them, because of course every overheating of the body can produce inflammatory process. So if they are in acute phase, definitely this is not recommended. But if they are in the relapse form, why not? Why do not them to live normally if they would like to?
We have there's a kind of a famous lady in the United States. Her last name is Wall, WAHL, and they have what's called the Walls Protocol. So she was in she had severe degenerative MS and basically healed herself through lifestyle changes, dietary changes. Cause like in that autoimmune profile, not only diet and exercise, but we also have like usually like a severe stressor that's in their life and things like that. So you're kind of weaving this into your treatment with your patients, kind of.
Look, if the MS is presented, you cannot stop it anymore. So you can of course work with the stress factor, because they can product the inflammatory process,
put in remission.
Exactly. So it's absolutely so important to work with these risky factors, which are, and they are pretty nicely named, because this diagnosis is, I think, well known all over the world, and there are a lot of articles right there. I've been on the one very good course which was focused on the treatment of the MS patients with really different perspectives from the psychological side, as far as the dietary restrictions, as far as some kind of the social care and rehab and the activity of the pelvic floor, which is limited, the optometrists, because they are losing the ability to see nicely and precisely. So it's perfect that those type of the diagnosis, do they have a protocol for the care according the symptoms and according the stages of this illness.
And as a therapist, how interested or curious, I guess, are you on their image finding? Usually in the MS profile, we have a brain MRI, we have a spinal MRI, they get repeated every year. Are you paying attention to that? Are you paying attention as far as progression, but are you also paying attention to locations of the plaques and lesions that might change treatment? Or
absolutely, yes, because it's supposed to correspond.
Right.
Yeah, so the findings have to correspond with the actual presentation of the patients. And it's fine to know if I can see some regression. I can accept or the estimate that some plaques which been produced by the inflammation, they can reduce a little bit, and that's the reason why they are not affecting some centers or some tracts in the spine.
And there's some theories in the U.S. because we're diagnosing MS more now than we ever have.
Of course.
So why do you think? I mean, one argument is, well, we're just recognize it better. I say that's bullshit, but like, why do you think that humans now are coming down with MS at a higher rate than they ever have? Like, what's the reason?
This is only my opinion. That's really, it's not evidence based. I think that we live in a very stressful time, and we are not learned how to fight with it. We are not resilient enough to really be strong against maybe small irritations. So also the very small irritation make a process of the stress reaction in our body. And as this stress reaction is accumulating in our body, it can proceed into the MS presentation.
What was it about Pavel Kolaj that we've all been mesmerized by this man. Like, what was it the first time you saw him that you just like were locked in and were like, I have to, be a part of this?
I have seen him for first time in my life in my university education. And I had a feeling somebody's opening my eyes. Really, I said, how come that I didn't meet this guy earlier?
Yeah.
But anyway, in my university education, all the time I had a feeling that everybody names the treatment according to him. Okay, we are doing the Atlanto-occipital treatment. We do the foot treatment. We do the hand treatment. We are stabilizing and mobilizing the basic joint of the thumb or whatever. Yeah, and we are doing it like a big treatment because it's according to us. And he came and said, every treatment finally will result in the same thing because all of us, we would like to affect the central nervous system. I said, yeah, probably he's right.
So, what he said.
Yeah. So that was my real an eyes-opening moment for those time of the university education. And if when I've got an option to come to Prague and to speak with him, it was really I've been completely sweaty. He's a very gifted and talented guy, gifted by God or whoever is over us. And he's able to collect his experiences with the breaking from the very, very injured kids as far as the top athletes. And those experiences together makes a sense for me.
And I feel like DNS we're just in our infancy, and I feel like even in 15 years, it's evolved so much. What do you think?
Oh my God.
For the better. What do you think the future holds for DNS? Like, what do you see continuing to evolve?
I don't know what will happen. What I believe in, it's that we will keep our holistic approach. That we will do not lose this point of view that we are observing not the shoulder, not a neck. We are not observing knee either, but we want to observe entire person because this is important to watch the person by itself because it has some central nervous system activity which we can read, and this is a miracle for me.
Well, I think I was lucky enough to have you instruct our ipsilateral pattern workshop during the D course here, and we were talking about crawling was the topic, and so you were asking some good questions and getting us some feedback, but your eyes didn't let you down, and so you kind of found something maybe that we didn't recognize right away, and so I feel like experience got you to that point, which is what you said. But do you have any more inspiration for getting better at that? Like, how did you get better at recognizing with your eyes and not your hands oh, I need to explore this area of the body. To your comment about the holistic approach.
Yeah. So still, I say this thing also to my students. Only practice makes a master. So just practice.
Yeah. And is it just watching people move so many times, or is there maybe something that you've done to, I don't know, organize it in your brain?
I think what helped me a lot was my personal experience, because I've been doing the exercises which are provided as an acrobatic exercises on the scars, and like acrobatic scars. And as I've been upside down, I needed to realize where is my shoulder, where is my hip, and how to move against the hip, which is higher than my head, but anyway, I need to activate the enclosed kinematic chain. So it was really like mind-blowing feeling, and those situations helped me a lot to understand how the movement can look like. And that's why a lot of things are really connected with the eyes, but also with the proprioception for me.
I think too, what's a little bit different than them and like Americans in other parts of the world. And I talked to Martina about this literally 15 years ago. She said, well, they get together and they workshop and practice the actual techniques. I feel like in the United States, you're more likely to work more on the theory side of things. So you're going to go to a coffee shop and you're just going to read stuff, when really to really get good at this, you have to be like implementing and actually practicing it with each other. I think that is one thing they do way better than the typical students that, you know, we're dealing with.
Probably is, but this is something what I cannot compare.
But you did that early on. I'm assuming you guys would get together and practice and work.
Yeah, of course. This is the main point, and a lot of people are more interested absolutely with the kind of the practical stuff. They are not keen so much to listen to theory.
Beautiful. What a great conversation. So I
think we made an argument for DNS for the neurologically compromised patient, because like a lot of people like just think that it's eyewash or it's just not necessary and things like that. And I think that this is a really, really important message, because these patients are probably the most neglected patients. You know, you're in a wheelchair, therefore, like, you know, you're basically left for dead, you know, and there's so much amazing things that can be done with these patients. So
yeah, if anything of this can help anyone to find out the power to start with the work with these patients, I will be very happy, because those patients are so important, and they will be, the numbers I will just increase and increase. We need to realize it, and we have to work with it, because also they would like to live normally, or as normal as it is possible.
Yeah, beautiful. Thank you so much for educating us. Thank you for being a teacher for me today. Can't wait for the rest of the week. So
thank you very much
jealous.
for
You're getting
invitation.
out of here, which is great, because I get some more time with.
I think
Julia,
the one thing you always hear about Yulia, the most underrated instructor. Man. Like people are like, "Oh my God, who is this lady?"
I
like,
told you
like,
today. Yeah, absolutely. Yeah. So she's
that's what you said to me when I saw him for the first time today, and she's like, "Wow, that is
So she's coming to the United States. We don't know when, but we're going to get her in Troy, and
we will show you.
It will be my pleasure.
Yeah, definitely. So thank you so much.
It was my pleasure, guys.
Keep looking global. I think that's another theme of our podcast, is keep looking global, keep looking distally, keep looking in places that the pain is not, and dysfunction will start to appear to you, and you'll start having.
And you got to start with these patients somewhere.
He's very clever.
Yeah, you got to start with them somewhere. So just start.
Don't be afraid of them.
Yeah, exactly. Yeah. Just start. They're human beings too, and they need help. So love it. Thank you so much.
It was my pleasure.
All right, guys.
Thank you.
Have a good day. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.